By now, courtesy Dr. Velu, we know this. It was called minimal residual disease, and today it is called measurable residual disease. This is a very simple diagram to explain an undergraduate student that if your disease starts here and you produce what is called hematological remission, somebody can relapse. This particular person had complete remission, but his MRD was positive. There can be another gentleman who also got into remission and whose MRD became non-detectable. But again, he relapses. And there is a third gentleman who goes into hematological remission, whose MRD becomes non-detectable, and gradually with the passage of time, the last cancer cell from his body disappears, and he is genuinely cured. That is what we are looking at today. It's my privilege to cover the subject of MRD in the field of chronic myeloid leukemia, chronic lymphocytic leukemia, and multiple myeloma. This will be something like yesterday, today, and tomorrow. When I say this, I mean something. To discuss MRD with respect to chronic myeloid leukemia is like past, because this is now in the curriculum of an MBBS student. His textbook talks about MRD of CML. When you talk about MRD of CLL, that is in the textbook of an MD medicine student. And when you talk about the MRD of multiple myeloma, it is meant for the DM student. So this is our past, this is our present, and that's our future. Jagdi Sequera from Goa is my patient of CML, whose BCR-ABL became negative 10 years ago. He's off treatment since last 7 years, and to me, he's cured. Assessment of MRD is like avant-garde of CML. What is avant-garde? It's a French term, and the Cambridge Dictionary tells you that avant-garde is something that is new, unusual, experimental, innovative, original, unconventional, and never seen before. CML is an example in medicine, in oncology, and in hematology, where there were many things which were avant-garde. The PH chromosome, the BCR-ABL, and the so-called biological cure. All these are examples with respect to CML. What is the technology that you use for detecting MRD in CML? It is PCR. And what's the sample you require to study this? It is just blood and not the bone marrow. So you look at the BCR-ABL by international standardized assay. The technique is quantitative PCR. Role is to monitor the treatment response of a patient of CML who is on tyrosine kinase inhibitor like imatinib. This monitoring is in a dynamic fashion, and the goal of the treating physician and the lab assessing it is to look for the deep molecular response. And the final goal is to put this patient into TFR, that is treatment-free remission. So if you begin your patient here when he has got 100% of BCR-ABL positivity, with the TKI treatment, there is a log reduction. It goes on, and a stage comes when you reduced the BCR-ABL to MR4 or MR4.5. And this is the definition of deep molecular response to the log of 4, 4.5, or even 5. And that's your prime goal when you are giving TKI to any CML patient. You do it at various intervals in the first year, 3 months, 6 months, 12 months, and later. The optimal response at 3 months is that the BCR-ABL ones become less than 10%. At 6 months, less than 1%. At 12 months, less than 0.1%. And that should continue, and when it reaches below 0.01%, you start talking about treatment-free remission with the patient. In case at any stage the BCR-ABL starts going up, you look at whether there is a BCR-ABL 1 kinase domain mutation. And this is done by sequencing. And these are the various types of mutations you may be looking for. The one in the red are the ones which are common and accounting for 70% of these mutations. Based on the mutations, and with these kind of charts, you decide which drug to move to. If that mutation is in the green zone of nilotinib, that's the drug. And if it's in the green zone of dasatinib, that is the drug. And if it's in the red zone for all three of them, then you move to either ponatinib or transplant. TFR is the baby of our French colleague, Franco Xavier Mahon. Way back, 11 years ago, he showed that once you achieve deep molecular response and you maintain that for about 2 years, and if you stop TKI, at least about 40% of patients will never become BCR-ABL positive again, and therefore have got a biological cure. Various guidelines have been put down by NCCN and others to tell you who is the patient where your TKI can be stopped. And this in the green tells you that institutional criteria are met. Sokal score at the beginning was not very high. The BCR-ABL transcript was something which was studyable. The chronic myeloid leukemia was in chronic phase at diagnosis. The response to the first generation TKI as a first line was optimal. Total duration of TKI therapy at that time was said to be more than 8 years. Today we call it at 4 to 5 years. The depth of molecular response is 4.5, and this lasted for 2 years. And that's the patient who can go off treatment. So, my friends, measurable residual disease in CML is simplified, and therefore it's a part of curriculum of an MBBS student. We have almost conquered CML. When I say that, and before you become ecstatic, remember one thing: 60% of patients who achieved deep molecular response and maintained it, and where you withdrew TKI, relapsed. And that is because you have not eradicated the leukemic stem cells in those remaining 60% of patients. And that is, for the youngsters who are listening today, a food for thought, food for research. I go to my second subject, chronic lymphocytic leukemia. And this charming lady from Coimbatore is my patient, Meenakshi T. I put up this particular lady because she is one of those fortunate ones where I can use the word biological cure. And I'll explain you what I mean by this, because this is not the terminology you commonly use for chronic lymphocytic leukemia, but that's the triumph of MRD in CLL, that you can do this. That's the classical morphology of chronic lymphocytic leukemia. The technology that is used to detect MRD in chronic lymphocytic leukemia is from either bone marrow or peripheral blood. So you cannot apply this technology like CML always to the peripheral blood. In good number of patients, it is bone marrow, but it's possible to do it from peripheral blood. And what are these technologies? Unlike CML, the one which is most popular and widely used is the flow cytometry, including, if possible, the NGF, the next generation flow. The second technology is PCR based using ASO PCR. And I must say that in front of the third technology that I'm going to tell you, this has become obsolete. And the third technology is NGS. So in short, you've got two technologies which are standard for today, the flow and the NGS. Let us talk about something which is widely used all around the world and also India. And that is the simplest, not the, is the simplest, the conventional 4-color flow cytometry. The 4-color flow cytometry using CD19, CD25, kappa and lambda gives you a sensitivity of 1 in 10,000 cell, that is 10 raised to minus 4. This technique requires a sample which has to be fresh and preferably less than 48 hours old. The procedure is widely standardized across many institutions, including in India. It is directly quantitative and the result is very quickly available. The limitation of this is its low sensitivity, picking up one cell in 10,000. As far as ASO PCR is concerned, the technique requires patient-specific primers. That's the first hurdle. It has better sensitivity of picking up a cell 1 in 100,000, 1 in 10 raised to 5. It works on the principle of detecting a disease-specific mutation in immunoglobulin heavy chain variable region. It does not require fresh material, but the DNA has to be extracted in the first 48 hours. The approach has been standardized, but it has got 3 major limitations. The technique is not directly quantitative. It requires a baseline sample, and if it's a follow-up patient to you and a new patient, then you can't do anything. It is time and labor intensive as well as expensive, and that's why it's no more practiced. The NGS. NGS is a highly sensitive measure of MRD, and it picks up a cell 1 in million, that is 1 in 10 raised to 6. Just about 1.5 years ago, in September 2018, a huge breakthrough occurred when US FDA approved clonoSEQ assay by one and only one Adaptive Biotechnologies based in Seattle for detecting and monitoring MRD from marrow samples of patients of 2 diseases, that is myeloma and B-cell acute lymphoblastic leukemia. This assay has also been used, though not US FDA approved, but also used to monitor MRD in various other B and T cell malignancies, and CLL comes there. And it has also been used from peripheral blood. So marrow, myeloma, B-cell ALL, US FDA approved, but rest all are state-of-art practiced by this lab. The clonoSEQ assay at NGS has a sensitivity between 10 raised to 5 to 10 raised to 6, depending upon the cell input. It's a very exciting technology which is being used today in several clinical trials, if not in the labs, not at the bedside. It's a very easy to perform technique which is reproducible, and therefore it reduces some of the subjectivity which goes together with flow cytometry. So which MRD assay should you and me use? Well, in general, the 4-color flow cytometry is the one which is most widely available and popular. Most of the data across the world, not India, across the world, has been validated at the sensitivity of 1 in 10,000 cells, 10 raised to minus 4. There are centers who have gone up to 10-color flow cytometry, but one is very comfortable in clinical practice in using 4-color flow cytometry, and this comes from the master, the ERIC, the European Research Initiative on CLL. What is the clinical utility of MRD in CLL? And that is very important to all the clinicians who are listening to me today. So you got a patient of CLL, you diagnose by flow cytometry. You put the patient on treatment and the patient is into so-called remission. And your pathology colleagues tells you that the MRD is so-and-so. either from the marrow or from the peripheral blood, by flow cytometry, by the next generation flow cytometry, or by NGR, whatever. So what is its use to you, the treating physician? So let's see certain conditions where you and me will use MRD. The first of this is a patient of CLL who's got IGHV mutated CLL and who does not have TP53 mutation or deletion 17p. And this patient has been treated by you and me by chemoimmunotherapy using FCR. In practice, this accounts to about 1/3 of the CLL. In this population, you can do MRD using 4-color flow from the bone marrow after 3 cycles. The standard of care is 6 cycles of FCR. You do it after 3 cycles, and if Jyoti tells us that it is undetectable MRD, you can stop further treatment, and very safely. This strategy has been based on the retrospective analysis of FCR 300 trial, which suggested that the outcome of these patients is similar to that of those who went on to complete 6 cycles at all the morbidity and a small mortality of 6 cycles. So that's the first triumph of MRD in CLL. And the next one. Today we have BCL2 inhibitor venetoclax as the treatment of CLL. And there is a fixed duration therapy for the first time in the history of CLL using venetoclax. So the second use of MRD is when you're treating your patient with venetoclax-based fixed duration therapy. I'll give you an example of 2 trials. The CLL14 regime, which is venetoclax with Gazyva, that is obinutuzumab, in treatment-naive CLL, that is first-line therapy. This is a treatment which is given for fixed duration of 1 year. And the second example is the Murano study, which is for the relapsed setting, and when that is venetoclax is combined with rituximab, and the duration of treatment is 2 years. So you treated your patient for 1 year upfront or 2 years for relapsed patient, and after that, if the MRD is positive, this is a treatment which can put you into MRD negativity in a large number of patients. But if your MRD is positive, you can continue venetoclax as a monotherapy, and the MRD response will deepen and deepen. Published 1.5 years ago in New England Journal. So that was the second utility of MRD in CLL for you and me. In clinical trials, researchers are evaluating the possibility of either lengthening the therapy or adding another novel agent based on MRD status. So your MRD is positive, you continue your treatment or add another novel agent. In a study presented at the 2019 ASH December, there was addition of venetoclax to ibrutinib-based treatment. And we all know that on ibrutinib, there is nothing like MRD negativity, the disease persists. So adding venetoclax to ibrutinib was the data presented in ASH December. This regimen leads to the deep remission and probably can lead to discontinuation of therapy. When not to do MRD, assessment of MRD makes sense only in patients who have been treated with agents or combinations which are capable of inducing deep remission. Therefore, if you are treating your patient with chemoimmunotherapy, like chlorambucil rituximab, bendamustine rituximab, or FCR, or if you are treating your patient with BTK inhibitors, like ibrutinib or acalabrutinib, or you are treating your patient with monoclonals like rituximab or obinutuzumab, there is no need to ask Jyoti to do MRD assessment, because you know that none of this can give you MRD negativity, except that rare example of FCR for a particular group of CLL. Notably, BTK inhibitors and monoclonal-based therapies were always designed for a continuous lifelong therapy. It would be helpful to have the option of discontinuing a regimen like BTK inhibitor with MAB, in which undetectable MRD today is approachable to the extent of 1/3 of the patient. And this is the part of trials at the moment because the mAb used is different. It's not rituximab, it's obinutuzumab. So when obinutuzumab is combined with either ibrutinib or acalabrutinib, you need to look at MRD because some patients somewhere will become negative. Based on the current trials, future of CLL therapy is largely going to be MRD-based fixed duration therapy made up of venetoclax MABs or venetoclax with BTKI or even venetoclax BTKI inhibitor and MABs. CAR T is future of CLL therapy. Researchers are assessing MRD as an exploratory parameter in patients receiving CAR T therapy for CLL, which could tell you that the patient has a potential of cure. Prognostic value of MRD. Looking at progression-free survival and overall survival. A retrospective analysis evaluated prognostic value of MRD in the real-world setting across different treatment modalities. And look at the results. After a median follow-up of about 10 years, the median PFS was 7.6 years for undetectable MRD, 3.3 years who had low levels of MRD, and 2 years who had high levels of MRD. So doing MRD gives you what is likely to be the progression-free survival or the time to next treatment. The median overall survival also similarly was 10 years, 5 years, and 3 years. Is the depth of response important? Just MRD positivity or negativity is important, but whether it is 10 raised to -4, -5, or -6, is that important? This was studied in Murano study, where venetoclax versus bendamustine with rituximab were compared. And they looked at low versus high MRD positive status. This study showed a correlation between depth of MRD and the type of treatment given. Similarly, from MD-ACC, Thompson looked at undetectable MRD to the sensitivity of 10 raised to 6 in his group of patients. And I'd like to show you some of these curves. Now, the gray curve over here, which is at the bottom, is for lowest level of MRD achieved. So the worst outcome. These are the patients who are alive. And if you look at where MRD level was more than 1%, the survival was least. This is IGHV mutated, which is a good thing to happen with MRD negativity. And look over here. With FCR, as we discussed, good number of patients will be MRD negative for the rest of their life, biologically cured. And that's where Meenakshi T, our patient, fell. And that's why I have to show and quote that patient to you. MRD negativity in patients who have or who do not have 17p deletion. And you look at it, the one who do the best or who do not have deletion 17 and became MRD negative. This is effect of undetectable MRD on progression-free survival by Thompson's MD-ACC group. And this was from peripheral blood. Another triumph, because when you can do it from peripheral blood, patient does not have to have the agony of undergoing bone marrow puncture. And this is from the bone marrow. And you look at the depth of MRD, and this is the various degree of MRD and various kind of responses. And this last picture tells you that when MRD by NGS and multi-parameter flow cytometry both are positive, then the chance of relapse is highest. And when both are negative, probably you've got the least chance of relapse. This is MRD as per duration of treatment. And you've got, this is the MRD less than 0.001. As you continue your treatment beyond 2 years, this becomes deeper and deeper. And this is the Murano study. On the left side, you have venetoclax, right side, you have bendamustine. The green bar is the deepest of the MRD, and you can see how it is successfully achieving MRD negativity versus bendamustine. So to summarize my second part of the talk, that is CLL, prognostic tool, because MRD tells you how long will be the progression-free survival, overall survival. Duration of FCR therapy, 3 cycles or all 6 cycles in IGHV mutated patient, not having deletion 17p, not having TP53 mutation. A definite or indefinite period of therapy, 1 year, 2 years or longer in all the patients who are venetoclax based. So this is for the clinician. I come to the last part of my talk, and that is myeloma. And our patient for myeloma is Satyendra Sen from Purulia in West Bengal. The technology here, unfortunately, has to be only bone marrow. Remember, for CML, it was peripheral blood. For CLL, it could be done from peripheral blood, but marrow is preferred. While here, it has to be bone marrow, and that's unfortunate because it's painful. The technology here goes beyond. So you have flow cytometry, you have PCR, you have NGS, and you also have imaging. And on top of that, you have liquid biopsy. So here you look at your quality of response by serological test in the form of immunofixation, serum-free light chain assay, and then multi-parameter flow cytometry, then PCR, and then NGS. And you have the depth of MRD negativity. Traditional methods are serological, which we just mentioned, and the morphological, where you do the bone marrow and just look at the plasma cells. And the present methods for MRD are flow and NGS, giving you a sensitivity of almost 1 in 10 raised to 5 to 10 raised to 6. Both flow and NGS have their pros and cons. Both have many limitations. Though Jyoti will discuss them at length, but I must say that myeloma, unlike CLL, is a very patchy disease. So there's a huge sampling error when you do the marrow and give it to Jyoti for doing an NGF. And doing marrow is a hindrance to look at MRD repeatedly because patient does not like it and you don't like it. And also this totally misses if there is an extramedullary disease. When you're doing bone marrow for MRD, it is of utmost importance that the first full sample is given for the MRD analysis and not the last sample, because that will be the most diluted sample if you go for the last sample. As stated earlier, in 2018, US FDA cleared the NGS clonoSEQ assay by Adaptive Biotechnology Seattle for multiple myeloma from bone marrow. The addition over here is the technique of imaging to detect MRD. So PET scan is a metabolic scan. It's an excellent tool to look at extramedullary disease. And now it is included in the recent IMWG response criteria. So besides doing flow and besides doing the sequencing, it's extremely important that you look at the patient's extramedullary disease and use the term like PET-CR or PET-PR. This can be done at multiple occasions: before transplant, after transplant, during maintenance. An SUV max of more than 4.2 is a poor prognostic factor. There is no way PET is a replacement for the marrow-based test. They have to be additive to each other. And today one is talking about what is called immunoPET, where you use an antibody against one of these 3 antigens, that is CXCR2 or B-cell membrane antigen or CD138. And by that, you can use a PET to look at the bone marrow. And that may make PET a complete test. Last test is the liquid biopsy. Under that come 3 terms: looking at the cell-free or cfDNA, looking at circulating tumor cells, the CTCs, and looking at the minute quantity of serum monoclonal immunoglobulin. So liquid biopsy is an alternative approach of tracking residual disease. The advantage of this is, and that's the superb advantage, is that you do it from peripheral blood. It's a very effective and sensitive technique, and it mirrors the bone marrow, and it also mirrors the PET scan finding. It monitors the disease kinetics. It can predict subsequent relapse, and theoretically at least, this becomes the ideal test. It's also attractive to the clinician and patients because it is painless. We have to wait for this to become a standard of care for our patients anywhere in the world. Nowhere it is being used at the moment in the clinical practice. So that cfDNA. cfDNA comprises degraded DNA fragments which are released in the blood from cancer cells. The current evidence shows that cfDNA can be used for mirroring the genetic landscape of bone marrow-based tests like NGS, and it can be recapitulate the spatial intracellular heterogeneity. Circulating tumor cells. From long time we have been talking about plasma cells in the peripheral blood. So circulating plasma cells constitute the second component of liquid biopsy, which has clinical utility. The increased frequency of CTCs has been proposed as an unfavorable prognostic factor for myeloma, both at diagnosis, after transplant, as well as at the time of relapse. Different approaches with various sensitivities have been used to enumerate the plasma cells in peripheral blood. And the three techniques listed here are immunofluorescence, multi-parameter flow cytometry, and the molecular techniques. Lastly, serum immunoglobulin component. We know that myeloma is characterized by presence of M protein in serum or urine in almost 98% of patients. Now, this serum M protein can be used as an alternative biomarker for minimal residual disease tracking. The conventional electrophoresis and immunofixation fail to pick up the minute quantity of this immunoglobulin, and the only test is mass spectrometry-based assay, which is more than 2,000 times more sensitive than immunofixation. And that's a journal devoted to mass spectrometry. That's one of the ancient mass spectrometer, and that's one of the modern mass spectrometer. The sample enters from here. It has an electron gun. It is a magnetic ion. The ion's path bends under the magnetic force, and there is a detector. So what's the clinical utility of MRD to you and me in the field of myeloma? So in myeloma, MRD at the moment is a good prognostic factor. As Dr. Velunayak mentioned, today we have a better and most relevant predictor of clinical outcome, the strongest independent prognostic factor which surpasses all other prognostic factors. Risk of other adverse prognostic factor is reversed if you achieve MRD negativity. High-risk cytogenetics and the standard RISS staging system are relevant factors only if MRD negativity is not achieved. Once you achieve MRD negativity, it is immaterial whether you have high-risk cytogenetics or whether revised ISS stage was 3. In a meta-analysis, there was 60% reduced risk of progression and 40% reduced risk of death for patients who achieved MRD negativity. The median PFS increased from 26 months to 54 months, and the median overall survival moved up from 79 months to 104 months if the MRD became negative. And that is shown graphically. Outcome of FRD negative patients versus MRD positive patients. Another study, progression-free survival of negative versus positive patients. Another study of overall cumulative survival of MRD negative versus positive patients. MRD negativity stands independent of treatment modality. Whatever treatment you might have used, once you achieve MRD negativity, then it is immaterial from the angle of prognosis. This has been shown during various parts and aspects of treatment by evaluating MRD after induction, after transplant, after consolidation, and after maintenance, as well as for different patient categories, transplant eligible, transplant non-eligible, as well as in relapse setting. Today, the guidelines laid down by IMWG and NCCN recommend MRD assessment at the end of each step of treatment, after induction, after transplant, after consolidation, after maintenance. So this has entered the recommendations. CR with MRD positivity don't do well. So till yesterday we said CR and stringent CR and we're happy. But if the MRD is positive, they don't do well. A large number of patients achieve CR. Results from PATHEMA clinical trials highlighted that patients in CR who were MRD positive behaved just like partial response. It was also shown that if you achieve MRD negativity later, then it is as good as MRD negativity received earlier. Both will do equally well. So how long you take to achieve MRD negativity is immaterial. You have to reach there. This shows you the outcome of partial remission, near complete remission, and MRD negativity. Is the depth of MRD important? Yes, sir. Should we focus only on the positive negative results or go for the depth? So Parrot using NGS and Pavio utilizing NGF showed that MRD negativity at the level of 10⁶ have significantly longer PFS against the MRD of 10⁵ or less. So depth of response is important, and that is an advance. In 2016, the IMWG reported new consensus criteria for myeloma disease response, and that includes the depth of MRD. So those are the current response criteria: PR, VGPR, CR, and MRD negativity. Well, these are MRD negativity to its depth, -4, -5, -6. There are limitations and improvements of undetectable MRD. Patients with MRD negativity to the tune of 10⁻⁻⁶ may still relapse, often as extramedullary disease, occasionally even intramedullary. These relapses should be assessed whether these are just MGUS type or these are active myeloma, because these relapses, if they are of MGUS type, it does not matter. MRD makes you decide the treatment. And a couple of slides, I'm just going to show you the titles. Whether to do an early transplant, whether to do a delayed transplant, or whether not to do transplant at all can be MRD guided. Whether after transplant you should do consolidation therapy can be MRD guided. What should be the optimal duration of maintenance therapy can be MRD guided. Defining treatment failure molecularly and doing MRD driven early intervention when the MRD becomes positive is another therapeutic aspect. MRD as against PFS and OS are today becoming the endpoint of clinical trials, as a result of which all the studies that are being done today, if MRD negativity is achieved, that probably will be US FDA approved. To summarize last part of my talk, the emergence of MRD has proven as the most reliable marker of response and subsequent prognostication. Based on current evidence, the achievement of MRD negativity surpasses all other prognostic factors and reverses the risk stratification. It is therefore rational that present ongoing clinical trials consider MRD negativity as the exclusive or at least additional primary endpoint. Are we on a slippery foot? The answer is no. And the answer is no because all that I have spoken to you is gradually making indoor as a bedside. Well, thank you so much for giving this opportunity.